Hi, I'm Dr. Rebecca Burch. I'm a headache specialist in Boston, Massachusetts, and I'm pleased to be giving this webinar as part of the American Headache Society's First Contact Headache in Primary Care program. And I am going to be talking about migraine in pregnancy and lactation, covering both treatment and a little bit of diagnosis. And I'm really pleased to be covering this topic, especially for primary care, because this is an area where many people feel uncomfortable making treatment decisions, but it's also an area that's very important to be comfortable with because people who are pregnant and have migraine deserve to have their headaches and migraines and other symptoms treated. So why is this such an important issue? Well, migraine is very common during pregnancy. We know from epidemiologic studies in the United States that between 21 and 28% of women will have migraine during their reproductive years, and 80% of those women with migraine will have at least some migraine symptoms during some portion of the pregnancy. So migraine is common during reproductive years, and it continues through at least some part of the pregnancy in the majority of pregnant women. We also know that the hormonal changes of pregnancy can change how migraine presents or expresses itself. The good news is that as estrogen levels increase and then stay stable during the later parts of pregnancy, 2/3 of women with migraine will see improvement after the first trimester. But migraine with aura is a subgroup less likely to improve, and the estrogen levels that increase during pregnancy also can make aura appear or worsen. So that may first present in pregnancy and can be a little bit of a diagnostic challenge as well. So it's very active in terms of change and presentation during pregnancy. So I structured this to be very practical. And so I've got some questions that patients have proposed, and we're going to answer them as we go along. So here's question one. This patient comes in and says, I'm thinking about getting pregnant at some point in the next year or so, but I'm worried. I want to know if migraine causes any problems during the pregnancy. Are there any treatment options? Am I just going to have to suffer for the whole 9 months? I'm really worried about that. I'm scheduled for my Onabotulinum toxin injections next week. Can I continue those during pregnancy? Should I stop them? When should I stop them? So this is a really great example of a person who comes in knowing that they want to get pregnant in the future and asking for guidance. And this is a great opportunity for us to be able to reassure our patients that there are treatment options available and also talk about and really address any concerns they have about the relationship between migraine and pregnancy. This patient's concern is not unique. There was a study, a registry study of patients in a migraine clinic who were asked whether having migraine affects their pregnancy plans, and 20% of those people said that yes, migraine did change how they thought about pregnancy, and 20% were either concerned about or were planning to avoid pregnancy due to migraine. And the concerns that they reported, including worsening migraine disease activity or disability. So are their migraines going to get worse? Are they going to be severe because they can't treat them? Lack of treatment options comes up over and over again. People with migraine are really afraid of not being able to treat their pain, their nausea, and their other symptoms. And they are worried that if they do treat their migraine during pregnancy, is it going to have an effect on the health of the child related to medications or the migraine itself? So what we can tell our patients is that migraine does come with some increased risk during pregnancy. Epidemiologic studies show that migraine increases the risk of preeclampsia, stroke, and other vascular conditions. They are population level increases in risk. On an individual level, it doesn't change how we treat patients, but we do maybe do a little bit of higher monitoring and just keep a little bit of an eye out for any kind of changes in blood pressure or have a lower threshold for workup if there are any concerning symptoms. We can tell them that migraine does often get better as pregnancy progresses, and often it's just a matter of getting them through that first trimester, and that there are many treatments available. We are going to stick with them and we will get through it together. One thing that can be helpful if medication is the major concern is a visit to maternal fetal medicine, because often the MFM specialists are very comfortable continuing a lot of medications that we may not be without that kind of advice, and that can be a real anxiety reliever. We don't have a ton of evidence about safety of a lot of medications during pregnancy. Pregnancy is a reason for exclusion from a lot of studies, but I really want to encourage you not to think of that as a reason to avoid treatment. Treatment of migraine is necessary prenatal care. Migraine attacks themselves can have associated vomiting, which lead to dehydration, hypoglycemia, electrolyte imbalances that are not a great idea during pregnancy. We know that pregnancy-related job discrimination is a real serious problem, and treating migraine can reduce presenteeism and absenteeism from work, and that can reduce concerns about pregnancy-related job issues. There have also been several studies showing that poorly controlled pain during pregnancy is associated with both physical and mental health conditions, both during the pregnancy and afterwards. And a recent study showed that maternal stress is related to ADHD and other outcomes later in the child's life. So maternal stress is something to avoid, and pain is certainly a part of that. So I encourage you to get comfortable with what is possible to offer our patients. So a plan for thinking about how to treat in terms of preventive treatment, and this patient was asking about onabotulinum toxin. So onabotulinum toxin A and the CGRP monoclonal antibodies do need to be stopped 3 to 5 months in advance of planning pregnancy, but there's no evidence to suggest that there needs to be a long withdrawal period from any oral medications or oral preventives prior to pregnancy. It's worth keeping in mind that half of pregnancies are unplanned. So asking about contraception, family planning, and risk of pregnancy should be a routine part of care whenever these medications are given to people of reproductive potential. So then it's worth making an acute treatment plan. Most obstetricians don't see patients until 8 to 10 weeks, and primary care, if you're not one of the primary care who takes care of pregnant patients all the way through, it's at least worth having a plan for that initial period until the patient gets in to see OB. And pre-pregnancy is the time to start lifestyle optimization and behavioral treatments, regular sleep, good hydration, any issues with dietary changes that need to be made. If you're going to recommend something like biofeedback, a relaxation practice, acupuncture, those are all worth starting ahead of time so that those habits and treatments are ingrained before pregnancy even occurs. And again, I cannot emphasize enough the importance of reassuring patients that there are treatments available and we will be there with them. They will not go through this alone. So another patient comes in and has moved on to the next sort of stage of things. I'm trying to get pregnant now. I stopped my birth control. I've started tracking my periods using an app to do some fertility planning. What can I take for my migraine once I get pregnant? And then this patient had recently seen an article about acetaminophen. There was a publication suggesting we should stop using it. And what about the topiramate that I have? Am I going to have to stop taking that one? So this really gets into questions about the safety of medication during pregnancy. And here is just kind of a summary of how I think about treatment of migraine during pregnancy. Again, first looking at these lifestyle issues and adding non-pharmacologic treatments, because they're really the bedrock of treatment. And we listed these previously, but worth putting them up again if you ever use this as a reference slide, really looking at sleep, hydration, diet, and then any of those non-pharmacologic treatments that you can add in. Then optimizing acute treatment. And I tried to make this a useful reference slide. So first line, acetaminophen, metoclopramide, and diphenhydramine is considered relatively safe during pregnancy as well. If those don't work, triptans are the thing that I go to next. I prefer it to butalbital, and I'll explain why in a later slide. And then promethazine is useful for nausea, but also has good evidence as an anti-migraine treatment as well, anti-migraine pain. And then starting prevention, if those first two approaches are not effective, propranolol has the best evidence for safety for prevention of migraine in pregnancy, followed possibly by magnesium, and then amitriptyline and verapamil. The question of whether to continue prevention often comes up. The bottom line is that if it's a relatively on the safer end medication and the patient had really debilitating or severe migraines beforehand, we typically do continue. If it's a medication that has lower evidence for safety, and if the migraine was more episodic or less severe, we may do a trial of withdrawal and see how they do. But before we do any of this, we need to make sure that what we're treating actually is migraine. And this is especially the case if a patient is presenting with a new headache during pregnancy rather than a continuation of the migraine that they had before. Even though in the first slide I said that migraine is very common during pregnancy, migraine does not protect against other kinds of headache, and having a migraine history actually increases the risk of some forms of headache, and some of them are dangerous. So I've given a list of just possible causes of headache during pregnancy on the side of the slide, and the ones in bold are the ones that are increased by a history of migraine, and that includes preeclampsia, as I had said, stroke, cerebral venous thrombosis. It's also worth being aware that idiopathic intracranial hypertension can present during pregnancy or be worsened in pregnancy, and there are other disorders as well. The risk of many of these conditions increases later in pregnancy, particularly many of the vascular disorders. And as a result of this, any new or different headache during pregnancy should be evaluated. And if an evaluation is needed, if an imaging study is needed, an MRI without gadolinium contrast is the study of choice. And it is a good idea to work up headache if needed, rather than miss a potentially dangerous cause of headache in a pregnant patient. The one exception to this might be that if you have a patient who has a history of migraine, perhaps had an aura or two in the past, but hasn't in some time, and they have a visual change consistent with migraine aura and no other symptoms, so blood pressure is normal, there's no proteinuria, you may be able to sit on that for a little while and just kind of monitor. But especially in someone with very frequent aura later in pregnancy, that really needs a workup for preeclampsia. So assuming that we are treating migraine, here is a chart of the pregnancy safety of some of the acute treatments that are sometimes used for migraine. So again, preferred acetaminophen, diphenhydramine, and metoclopramide are in that top tier. NSAIDs are often used in the second trimester. In the first trimester, there is some question of whether they increase the risk of spontaneous abortion. And in later pregnancy, they are contraindicated due to risk of patent ductus arteriosus. If you have access to nerve blocks or lidocaine sub-Q, or if you do them yourself, those are also generally considered safe, and they can be a good preventive strategy if done once a month as well, particularly occipital nerve blocks. Again, second line, triptans, butalbital combination medications, and then some of the anti-nausea medications on ondansetron, prochlorperazine, and promethazine, as well as a short course of steroids. Aspirin says avoid when possible, but many patients take a daily aspirin because of hypercoagulable state, antiphospholipid antibodies, or things like that. And In some older patients now, daily aspirin is actually recommended. So I think we may in the future want to move that one up to second line when used occasionally. Things to be avoided include ergots, dihydroergotamine in particular is sometimes used for migraine treatment. The gepants, the new medications, rimegepant and ubrogepant, we don't have enough evidence regarding safety in pregnancy, and the evidence that we do have suggests we should probably avoid for right now, as well as lasmiditan, one of the other new acute treatments. So why do I say that I prefer triptans to butalbital? There is a very robust safety literature for triptan use in pregnancy. It's kind of a lot of small print here, but the bottom line, there was a post-marketing registry study showing no signal of teratogenicity, meta-analysis of 5 cohort studies and 1 case control study, finding that triptan use was not associated with an increased risk of either spontaneous abortion or congenital malformations compared to other people with migraine who did not use triptan. So it's migraine that may be a little bit of an increased risk for those things, not use of triptans. And then there was a cohort study that came after that meta-analysis that confirmed those results as well. On the flip side, there was a case control study, admittedly a small number of cases, but still there, that found a 3 to 5 times increased risk of congenital heart defects of various kinds in infants exposed to maternal butalbital. So while we don't have safety issue signals for triptans, we do for butalbital. And then the other issue is that triptans are often more effective, especially if there's a history of triptan response in that individual person. And they may also reduce migraine accompanying symptoms such as nausea, photophobia, phonophobia, those kinds of things. And it may result in an actual overall decreased medication burden if the patient is just allowed to take the medication that works for them. So for that reason, I recommend using triptans before butalbital as a second line treatment. Many OBs don't agree with this, and so it may be a discussion between you and them and the patient as to what they're comfortable with. I had also mentioned this question about acetaminophen. Acetaminophen has historically been the first line treatment for migraine during pregnancy, but a few years ago, a paper came out and got a lot of press. There was an observational study, a set of studies raising questions about whether acetaminophen use during pregnancy was associated with autism, ADHD, and language delay in some of the offspring of those mothers. The association is stronger with longer duration use, higher doses. And I think it's always difficult because it's impossible to completely sort out the effect of the acetaminophen use from the reason that the person was using the acetaminophen in the first place. And studies can only go so far in trying to figure out what those relationships are. So the recommendation is to use the acetaminophen only when needed and not to take more than is needed to treat the underlying condition, but that's true for all medications during pregnancy. So I still leave it as first line treatment, and I think we're going to have more discussion and hopefully more evidence about this in the future. But I just put this there because sometimes people ask about it. So here's a summary slide. My recommendations for acute treatment. Again, those first line treatments I've mentioned a few times. Triptans next, unless the patient has gestational hypertension or pre-existing hypertension. If there are concerns about placental sufficiency or any fetal growth concerns, because triptans have a potential relationship with vascular issues and hypertension, those would be a reason to not use triptans. I said an occasional aspirin is okay here, just because of the fact that it is sometimes used daily in pregnancy for certain conditions. Then followed by butalbital, phenothiazine antiemetics. Opiates in low doses for a short period of time are potentially an option as well if those other things don't work, and then always avoiding ergots and not using the new treatments. For rescue treatment, if acute treatment doesn't work, again, occipital nerve blocks have good evidence for safety. They can also be used monthly as a preventive strategy. A short course of short-acting steroids like prednisone, oral opiates, if nothing else is working, cyclobenzaprine can be helpful if the person just needs to go to sleep. And if it's in the second trimester, NSAIDs are a potential option as well. Here's another chart looking at preventives rather than acute treatment. Propranolol has the longest history of safe use in pregnancy, but we also have reasonable evidence for amitriptyline, nortriptyline, verapamil, cyclobenzaprine. Of the herbs and supplements, CoQ10 has the best evidence for safety. And then interestingly, memantine, which is sometimes used for migraine prevention, doesn't have a lot of evidence for any problems during pregnancy, but I also wonder whether that's because it's primarily used in an older population that's outside of the reproductive potential window. But it is, according to the available evidence, second-line treatment. Third line, gabapentin, pregabalin. I'll explain why magnesium is considered third line there. And then venlafaxine and onabotulinum toxin, I'll explain a little bit more about those. Onabotulinum toxin is probably moving up, venlafaxine probably moving down to the avoid when possible category, which already includes candesartan, lisinopril, topiramate, and the CGRP monoclonal antibodies. And then always avoid during pregnancy include feverfew, and that's sometimes present in a lot of migraine supplements, and then valproic acid. So venlafaxine is probably moving down to avoid when possible because of a 2020 meta-analysis that found that venlafaxine has a higher risk of poor outcomes, things like autism and ADHD in offspring compared to other antidepressants. So it's not preferred as a migraine preventive, although certainly it is often continued for maternal mental health. And then for onabotulinum toxin, we have increasing evidence for safe use during pregnancy, so that may potentially move up. So there have now been about 115 cases of onabotulinum toxin A used for migraine during pregnancy, and there has been no increased signal of safety problems. Most of the cases that are reported were just one set of injections that happened early in gestation, often before the person even knew that they were pregnant. And it's still a relatively small number of cases, but it is good news that we haven't seen any serious problems as a result of onabotulinum toxin use. It's pretty clear at this point that the toxin itself does not cross the placenta. It's a very large molecule, and one of my, I guess not favorite, but certainly most memorable case reports I've ever read is of a person who got botulism when they were pregnant, and it says at the most intense point of the disease, when the patient was almost completely paralyzed, fetal movements were the only visible motion. So it's pretty clear that even maternal botulism, does not cross the placenta and cause problems during pregnancy. The new treatments, CGRP antagonists, come in both the short-acting small molecule receptor antagonists. These are the acute treatments that are used, rimegepant and ubrogepant, as well as the preventive atogepant, and then the monoclonal antibodies that have a much longer half-life. Those are the injectables. And CGRP is active in maintenance of placental vessel relaxation, and there is some experimental evidence suggesting that abnormal vascular response to CGRP. So if CGRP helps the placental vessels to stay open, an abnormal response to CGRP is one of the potential contributors to the development of preeclampsia. Since people with migraine have an increased risk of preeclampsia already, it follows logically that we would want to avoid anything that may, interfere with the CGRP's role in placental vessel relaxation even further. So in the absence of data suggesting safety in humans, the recommendation is to avoid all of these treatments until we have more safety information. Oral magnesium has historically been used as a migraine preventive, and it's an oral treatment, and the oral bioavailability is, not that great. But it's become a little bit controversial because IV magnesium at high doses is sometimes used to stop premature labor, and when high dose IV magnesium is used for more than 5 days, it interferes with fetal bone development. And so there was a safety warning put out for IV magnesium. And so that led to a question of whether that warning should also be extrapolated to oral magnesium. And if you if you ask headache specialists, you're going to get a bunch of different answers about this. Some feel it's completely safe and continue using it. Others cite safety concerns and have stopped using it completely. The bottom line is we simply don't know. I just have this discussion with patients and give them the option. I personally feel pretty comfortable using it because the doses are so much lower and it isn't absorbed all that well, but it's definitely a conversation to have with the patient and document that you had it if you are going to use it. Vitamin B2 simply hasn't been studied at the supraphysiologic doses that we typically use for migraine prevention. CoQ10 has some evidence from a single randomized controlled trial during pregnancy. Kudos to the authors for looking in this population. Feverfew is contraindicated due to a risk of spontaneous abortion. Butterbur is also contraindicated. Ginger is safe and can help with nausea. And so that's something I often recommend to patients with nausea during pregnancy. And just a note that several combination supplements with the migra in the name are available. Many of them contain either feverfew or butterbur, and it's very difficult to tell from the name. So people need to either look at the labels or simply not take those during pregnancy. So my take-home recommendations for preventive treatment, propranolol is first line, followed by amitriptyline or verapamil, scheduled nerve blocks if you have access to them. Maybe this is where magnesium fits in. I didn't really talk about cyproheptadine because tolerability is a major limitation. It makes people sleepy and gain weight, but it is relatively safe during pregnancy, as is cyclobenzaprine. Onabotulinum toxin for patients who are stable and absolutely needed, who have not responded to anything else, and who are able to provide informed consent. I think it might be reasonable to continue in that population. And then everything else should probably be avoided for the purpose of migraine prevention, although of course it's individualized, and this is where maternal fetal medicine can be really helpful. So here's our last patient. I was so much better during pregnancy, especially later on, but since I had the baby a month ago, my headaches have started to come back. I'm trying to breastfeed. I don't know what's okay to take. Can I restart my rizatriptan? Should I go back on my propranolol? What should I do? I just don't want to be out of commission when I have this young baby. So postpartum headache is very common. A third of women experience headache in the postpartum period, and half of women with migraine have a recurrent headache within the first month. And there are a number of reasons for this. Estrogen levels kind of crash in the immediate postpartum period. There's sleep deprivation and sleep interruption. There's sometimes emotional stress and a lot of lifestyle changes, dehydration, changes in eating patterns. All of these things happen, and all of them can contribute to recurrence of migraine in many people. But just again, like with a headache during pregnancy, there are a number of not benign causes of headache in the postpartum period, and it's actually one of the most sort of dangerous or vulnerable periods. So cerebral venous thrombosis, preeclampsia, postpartum angiopathy or RCVS causes thunderclap headache and is more common in the very late stages of pregnancy and immediate postpartum period. And then low pressure headache, post-dural puncture headache is actually the most common cause of secondary postpartum headache. So taking a good history and especially an obstetric anesthesia history is important as well. Once you've convinced yourself that it's migraine, here is migraine treatment during lactation, just in one slide as a summary. So avoiding aspirin, ergots, lasmiditan, one of the new treatments, atenolol, it's a different with the atenolol versus the other beta blockers, and then venlafaxine. There's no real good evidence for use of triptans in lactation, but they are often used, and there have not been any safety signals identified. Of the triptans, elatriptan is the highest protein, has the highest protein binding of all of the triptans, and so has likely the lowest excretion in breast milk. So if a patient can do elatriptans, probably good to try that one first. If not, going to the other triptans is probably okay. Acetaminophen, you can use NSAIDs here, unlike during pregnancy. Propranolol, magnesium, and verapamil are all compatible preventive choices with breastfeeding. Amitriptyline, topiramate, gabapentin, cyclobenzaprine, and then here valproate is okay, unlike during pregnancy. All of this assumes that this is a normally developing baby with no feeding issues. There's no question of sedation being an issue or anything like that. If there are concerns, always possible to talk with the pediatrician and come up with a plan together. And minimizing exposure is better than stopping breastfeeding if there are concerns. So there are some techniques you can use to minimize exposure. So drug exposure to the nursing infant can be minimized by having the mother take the medication just after breastfeeding or before the infant is due to have a lengthy sleep period. I always laugh a little bit about that one as a parent of a child who was not a good sleeper as a baby, but if you can do that, good for you. And if absolutely necessary, pumping and then discarding that one pump can be a strategy as well. But having migraine is not a contraindication to breastfeeding. So in summary, migraines common during pregnancy, doesn't protect against secondary causes of headache. So you're going to see a lot of it, but it should also not rule out being concerned about any new or different headache. It does typically get better as pregnancy progresses, but not always. Acetaminophen still first line along with metoclopramide. Triptans have better evidence for safety than butalbital, so I think they should be moved up the list a little bit. There is no perfect preventive, but propranolol, amitriptyline, verapamil, probably the safest. Management in lactation is a little bit less restrictive than management in pregnancy. And again, there are so many options, and I hope that after this you feel just a little bit more comfortable knowing what to offer a patient with migraine during pregnancy or lactation. And I have given you a bunch of review articles, many of which are relatively short and have a lot of nice summary tables and things, and then some websites that have a lot of really helpful information as well. So I hope this was useful to you, and thank you for your attention.